Good morning. I was writing some notes because I haven't sat in a lecture on Parkinson's disease probably in 25 years, and there's some new stuff that will hopefully inform my interactions with patients with Parkinson's. So I have a long list of things that I want to talk about, but I think understanding normal urination and the impact of aging on urination will give us a framework to understand the overlay of the impact of Parkinson's disease on urinary concerns. And why this is important is that it's kind of like a Venn diagram. We all get older, and most people as they age develop symptoms of the urinary tract. And then if you happen to get Parkinson's disease, eventually, you'll have additional urinary symptoms in most cases that would be attributed also to Parkinson's disease. So with enough time, there's a double whammy. And our treatments are not especially specific to the treatment of Parkinson's disease-related urinary symptoms. We're using the treatments in most cases that we would use for any of these symptoms from another source, including those that are common with aging. So let's start with the basics. Most of the time, until we're on stage and have had a couple cups of coffee, we don't think about urination, right? So the bladder basically has two purposes. One is to store urine. And this occurs from relaxation of the bladder and tightening of the sphincter, or the valve that holds the urine back. And this happens without conscious thought. Then the bladder has to empty. When the time is right, the bladder squeezes in a coordinated fashion with the sphincter or the valve relaxing. And again, for most people, this happens with no conscious thought. And even after we're potty trained, when we're out of diapers as a 3 or 4 or 8-year-old or 18-year-old, it's surprisingly prevalent how common accidents are in the teenage years. It becomes a subconscious ability to inhibit the urge to void at our convenience. So like, I'm going to wait till the break instead of the middle of this talk, whether I have to go or not. And we do that without thinking about it. So we have a balloon that slowly fills, and then we have a baffle that squeezes. All right. So maybe the next slide. It's a little more complicated than that, right? Of course. So how does the brain inhibit the bladder from squeezing in a reflex fashion as the bladder fills, which is what happens before we're potty trained? It has inhibitory signals that tell the bladder to relax and delay the urge to go to the bathroom. Also, that bladder has to fill at a low pressure. If there's high pressures, there's danger to the function of the kidneys. And in some patients with severe acute neurologic injuries or severe congenital neurologic abnormalities, the bladder pressures are high, and unless we intervene, kidney failure will ensue. So the normal urinary cycle is a complex interplay between neurologic, muscular, and anatomic organs. And most of the time, from age 15 to 55, we don't think about it. Next slide, please. So as we age, there's multiple organ systems that impact urinary system and symptoms regardless of the presence or absence of neurologic conditions. In the male, we blame the prostate for everything, right? It's the root of all evil. And after your reproductive years are over, it causes no good. It's only harm. And even though we blame it for all the problems, it's not the cause of all the problems, but we're right about 80% of the time in men. Regardless of gender, as we age, our bladder loses its elasticity. So we go to the bathroom more frequently, with more urgency, and are more likely to get up at night. And we can blame the prostate for that in men, but the likelihood of that happening is equal in women, and it's pretty hard to blame the prostate in women. In some patients, this will be manifested as overactive bladder. So this is when that urinary urgency and frequency happens so much or so often or such a degree that it is an impact on your life. And then you're susceptible to direct-to-patient advertising, in which case you might be compelled to ask your doctor for some medications to help with this. It may be also that it keeps you from giving a presentation because you got to pee, and it would be beneficial for you to have some control over that frequency and urgency of urination. Also, as we age, regardless of gender, we tend to make more urine. The urine production often happens more at night than it does when we're younger, and this has an impact on our urinary habits, and it's gender neutral. And finally, women, as they age, are more likely to develop pelvic organ prolapse, cystocele, rectocele, drop of the pelvic organs, which can impact urination, and they're more likely to develop stress incontinence, that is, urine when you leak, cough, or sneeze. And those are largely not symptoms that develop in men, unless they've had surgery on the prostate. Men generally do not develop stress incontinence of urine. So all of these things are happening as we age, impacting urinary symptoms, and they're superimposed in the background of patients who have Parkinson's disease. So they're very common. A general urologist will see a lot of patients with urinary symptoms. A urologist that specializes in neurologic conditions will see only patients with urinary symptoms. That's an exaggeration, but it's very prevalent, increases as we age. Next slide, please. One of the things that we do to assess the development of urinary symptoms are symptom scorings. Now, these tools, which may be administered in the clinic, are not useful for the diagnosis of the cause of the urinary symptoms, but they're useful in measuring the severity and the response to treatment. We also generally break urinary symptoms down into groups to help us try to figure out what the cause is. So urinary symptoms that are related to obstruction or blockage of urine flow, which might be due to, example, for enlargement of the prostate, or for a cystocele, dropping of the bladder in a woman, are difficulty getting the urine started, hesitancy, starting and stopping of the urine flow, intermittency, incomplete bladder emptying, feeling like you didn't get your bladder all the way emptied when you go to the bathroom, which sometimes is manifested by double voids. You get done, you go back to the kitchen, oh my goodness, I gotta go again. Maybe your bladder didn't get all the way empty, you're leaving the tank half full, so it's not long before you have the urge again to go. Some symptoms we consider as irritive, the loss of bladder contraction or elasticity, and they are usually manifested by the strong urge to go to the bathroom, more frequent desire to go to the bathroom than is normal or was previous, inability to hold the urine on your way to the bathroom, urge incontinence, and getting up at night to go to the bathroom, nocturia. Some urinary symptoms might give us a clue that there's an infection, painful urination, painful bladder. More frequent urgent urination also can be due to infection. We talked a little bit about incontinence of urine, leakage of urine. We broadly categorize those in two types. Urge, I can't get there quick enough. I have the urge to go, and I leak on the way to the bathroom. Often a whole bladder squeeze and a lot of volume. Versus stress, I have a bladder that's full, I laugh, I leak a few drops. And then one of the most challenging problems is urinary retention. You can't pee at all. And this is where urologists are a little bit like attorneys. You don't really want one until you need one. Right? And when you can't pee, you need intervention, you need a catheter, and eventually we'll need a urologist. So let's talk a little bit about the prostate. It's very common with aging, almost universal. Although the prostate may enlarge, not all men will develop urinary symptoms from enlargement of the prostate. The first symptoms are usually obstructive. You might notice a decreased caliber or force of your urinary stream. It may take longer to empty. You may have some of that starting and stopping or difficulty to get going, and those double voids I mentioned. A lot of men, this is a nuisance, but not enough to get you to the doctor, right? And there's often no harm from it. On the other hand, when you start getting the irritable voiding symptoms like urgency and frequency and getting up at night and it disrupts your day, that is often when patients will seek care. What are the treatments available to us for BPH? So BPH is the benign enlargement of the prostate. We attribute most male urinary symptoms initially to the enlarged prostate, and you don't have to have treatment. It used to be thought that you would inevitably get worse, and you might as well have your surgery today because I've got a boat payment tomorrow. But what I don't have a boat. But what we learned, the natural history of the urinary symptoms from an enlarged prostate are not inevitable progression, and a lot of patients can be observed without therapy. You can also try behavioral modification. In this case, I would be a hypocrite, and I would disagree with the 2 or 3 cups of coffee that the neurologist might recommend. If you cut back the amount of fluid intake and amount of coffee, you're going to urinate less frequently, and your bother from those symptoms might go away. You might also fall asleep during this presentation, and your Parkinson's might also be less well controlled. And so people often have done this before they seek care from a physician already. Some of it's self-evident. Most of the time we're going to start with medications, and in some cases we're going to do surgical intervention. So let's talk a little bit about what medications are available, and these would often be deployed in patients with Parkinson's disease and urinary symptoms if they're men. And the first group of medications is not a medication, it's an alternative therapy, herbal supplements, and they're widely deployed, very much advertised. If you're a fan of sports radio, there's always some super beta prostate maximum therapy available that will cure all your ills. And they're, in some cases, they can be beneficial. The herbal supplement saw palmetto has actually been studied pretty well, and it has a slight benefit over placebo in relieving urinary symptoms. It may cause, maybe less effective than traditional medicines, but a patient's in control, they can go and get it wherever they want, and it's not known to be harmful. But in general, the first line of therapies are alpha blockers. They were originally developed to treat high blood pressure, and people noticed that they urinated more efficiently. These medications work by relaxing the smooth muscle tone in the prostatic urethra. And the way I envision this is the prostate's like a donut. You're going to urinate through the donut hole. As we get older, the donut gets bigger. When we examine your prostate, we're measuring the outside of the donut with a rectal examination, the urologist's reading. But what's affecting urination is the donut hole, and that donut hole gets smaller as you get older from enlargement of the prostate, and the tone, the muscle strength in that urethra gets tighter. So it's more difficult for urine to flow through. So we're going to give medications on the first line that relax those smooth muscles and open up the donut hole a little bit and let urine flow through more efficiently. The classic one is tamsulosin, also known as Flomax. Urologists like it because it does not require dose titration. Most people take the starting dose for their whole therapy, and it's reasonably well tolerated. Side effects include nasal congestion. It relaxes the prostatic urethra. It tightens the smooth muscle in the nose, giving you a head cold. About 30% of patients will have those symptoms. It also is in that family of medications that are used to treat high blood pressure, so it can lower your blood pressure. And that's especially, it's not very good at that, but when you stand up, you can get lightheaded, orthostatic hypotension. I just learned today that that's a common manifestation of advanced Parkinson's disease. That sounds like a bad combination to me, right? You lose your autonomic, your nerve signals to keep your blood vessels tight, and we're blocking those muscles, so you stand up to go pee, and you're lightheaded. An alternative is 5-alpha reductase inhibitors. These medications actually shrink the prostate, and they take 6 months before we know whether they're going to work, and they're associated with the side effect of hair growth. Wait a minute, that's an advantage. And it's marketed to dermatologists for that, but also can cause breast enlargement and tenderness. It's a good long-term maintenance therapy and can prevent problems down the road. Tadalafil, also known as Cialis, is usually thought of a medication to treat erection dysfunctions, but it is approved by the FDA for the treatment of enlargement of the prostate-related symptoms. And has favorable side effects, but it costs about $300 a month, and most insurance won't pay for it. Those three medications are useful in treating the primary obstructive or blockage urinary symptoms related to enlarged prostate. And they have some secondary benefit in the irritant voiding symptoms of urgency and frequency. But many times we'll use an additional class of medications to improve the urinary frequency and urgency associated with enlarged prostate. And those are the subclass of anticholinergics called antimuscarinics. And these medications block the nerve signal to the bladder to squeeze. And the classic one is oxybutynin or ditropan, but it's associated with a lot of side effects. It has a short half-life, causes dry mouth, dry eyes, constipation, and cognitive impairment. So people aren't quite as sharp, especially as they age. And so there's new versions that are longer acting and less side effects, not necessarily more effective, but easier to take. And many times it's trial and error finding one that fits a patient well. In men with an enlarged prostate, we worry about weakening the squeeze of the bladder so much that you can't pee. So you have to be careful with these medications. There's a new class of medications for overactive bladder, urinary urgency, and frequency, and that's beta-3 agonists. So they relax the bladder by a different mechanism of action, and they have much fewer side effects of urinary urgency, of dry mouth, constipation, dry eyes, or cognitive impairment. The main side effect is increased blood pressure. So we have a lot of medications that we can use to treat symptoms that we attribute to the enlargement of the prostate. And we're going to use this same classes of medications for all of the urinary symptoms, regardless of the etiology. Next slide, please. So what happens if the medications don't work, your urinary symptoms are so bad? We can do some surgical treatments. The classic is transurethral resection of the prostate. That's the Roto-Rooter medicine. We're going to open up the channel. We're going to clean out the pipes. We're going to make the donut hole bigger surgically. There's side effects from that, and alternatives have come and gone. I used to be able to say in my short career at my young age, but even then, I had seen things come and go as far as alternative treatments to the enlargement of the prostate. The one that's popular right now is the UroLift. I'll show you a picture of that. And one that is still recommended by the guidelines for urologists is the microwave thermal ablation of the prostate. But no one does it anymore because it doesn't really work or doesn't really last, or it doesn't reimburse well. You can, next slide, please. So this is a graphical depiction of the TURP. So you can imagine the donut hole is being obstructed by the prostate here and here. We use this electrical loop to whittle out some of the prostate. Now you can use more fancy equipment. You can use a laser. You can use an amorcelator. But it all accomplishes the same thing. We put this loop in the bladder. We open up or whittle out the prostate. And then we create a big open channel, and urine can flow right through. So we're not relaxing or shrinking. We're actually removing blocking tissue. Next slide. Of course, you could envision that raw surface can bleed. Anything you cut can scar. So people have tried to come up with easier to recover from alternatives. This is the UroLift. It's a little hard to see, but there's these little cables that are inserted through the lumen or the donut hole of the prostate, and they spring open the prostate. So they stretch open the donut hole with these little cables. Very ingenious engineering kind of accomplishment. Avoids the removal of tissue, it kind of compresses it, and it allows for urine to flow through more efficiently. It was approved about 5 years ago in Europe and 3 years ago here, and we're starting to learn who the best patients for this are. And I could find no evidence that it's been studied in patients with Parkinson's disease. But to me, there's always been a lot of concern, and I'll say a little bit more about this later, about the safety of transurethral resection of prostate in patients with Parkinson's disease. And this might be a good alternative. Next slide, please. So we have a list of reasons in which we recommend surgery, and the outcomes are pretty good. But I want to point out one of the complications of surgery is the development of new incontinence. And this appears to be increased likelihood in patients with Parkinson's disease. So you go from difficulty urinating to incontinence. And for most patients, incontinence is a worse problem. Now, the data that developed this impression among urologists that there was increased risk of incontinence after TURP in patients with Parkinson's disease has been somewhat called into question because many of the patients in those initial studies had Parkinson's plus, especially multisystem atrophy, which I relearned today involves a lot more of the autonomic nervous system, and that explains when you don't have as good a sphincter control why you might have incontinence. So the current thought among urologists is if it's Parkinson's disease and not Parkinson's plus something else, and there's an indication to do a TURP, just do it. The likelihood of outcomes are no different than a similar patient without Parkinson's. But frankly, it's hard to convince a urologist to do that. And generally, we're much less aggressive about surgical treatment of enlargement of the prostate than we used to be. But it shouldn't be because of Parkinson's disease. Next slide, please. So I want to talk a little bit about frequency of urination at night. Nocturia more than once a night is relatively common, and it increases as we age. And this is especially problematic in patients with Parkinson's disease who have potential for mobility challenges. To get up and go to the bathroom can be fairly dangerous. We worry especially about falls. Next slide, please. And of course, urologists blame it on enlargement of the prostate, because you've already heard me say three times today or more that it's the cause of all trouble, but it's not. Fluid balance, so sometimes people drink too much. There I'm going to pick on the coffee drinkers, including myself. Or you have a couple of beers before bed. You're going to pee that off sometime, and if you can't get through the night. Heart failure and sleep apnea are two common causes of nocturnal polyuria, too much urine at night. Nondescript idiopathic overactive bladder, you can't fill as much or hold as much. And constipation. So the reasons why constipation impact bladder function are debated. You can have a mechanical view of the world. The pelvis is a funnel, and if the funnel is filled up with the rectum full of stool, there's no room for the bladder to fill. So just from a mechanical standpoint, constipation makes urination worse. It may be the same neurologic impulses that influence the rectum also influence the bladder. So we know that treatment of constipation is associated with improvement in urinary symptoms, including nocturia. For the urologist, we tend to ask for avoiding diary or a log of intake and output, so we can discern, are you making too much urine at night as the cause of your frequent urination at night, or is it your bladder can't hold enough? And the treatments are different. If the reason why you get up at night is because you make too much urine, we might be able to use a medication that we use to help children grow out of being bedwetters, and that's desmopressin or DDAVP. As we get older, we lose the production and sensitivity to DDAVP, and DDAVP tells the kidneys to make less urine so the bladder doesn't have to hold as much and you can get through the night. So you can take DDAVP as a pill or a nose spray, cut down on the amount of urine you make at night, and get a better night's sleep. It has side effects. The most serious is hyponatremia, low sodium level in your blood, which can cause a lot of problems, including changes in the way you think. So it's not widely deployed, but it is an old, new, kind of rebranded strategy to help with nocturia. Next slide, please. So I've already talked a lot about active bladder, especially in its context with prostate enlargement. In patients over the age of 50, 4% of patients will have a daily episode of urinary incontinence. If you get to age 70 or in a nursing home, it's astronomically higher. So this is a big problem. Sometimes it's small volume urine managed with a pad, change of clothes, change of underwear, but it can be, socially disabling and affect your skin and other health conditions. When we talk about overactive bladder, that means we've excluded all of the other causes, including neurologic ones. It's idiopathic. We're idiots. We don't know what caused it. And the treatment is usually focused on medications, and part of this is related to the development of new drugs that can be advertised to patients directly, but we have other alternatives. We can do behavioral therapy, physical therapy, behavioral modification, avoiding bladder stimulants like coffee, soda. And if those fail, there are some surgical treatments. There's neuromodulation. We have nerve stimulators, and we can inject Botox into the bladder. And I'll talk a little bit how those fit into the care of patients with Parkinson's in just a minute. Next slide, please. So the mainstay, though, as I mentioned earlier in the context of BPH are the anticholinergic, antimuscarinic medications, and they're effective at managing urinary urgency, frequency, and urgent incontinence, but they have the potential for profound brain side effects in the elderly. Some of the new formulations have less side effects, but they don't have no side effects. And as I mentioned earlier, the beta-3 agonists offer promise in this area. One of the medications, trospium, is claimed to have less brain side effects, and we tend to use lower doses, and it can be beneficial. Next slide, please. And one more. That's a transition. So I just want to say a little bit about female stress urinary incontinence, relatively common. The same kind of thoughts on treatment. You can try behavioral modifications and physical therapy. Physical therapy is actually very beneficial for stress urinary incontinence in some women. There are a limited number of medications. One off-label medication is Cymbalta. It's approved in Europe for that indication, but not in the United States. It has a mild effect on stress incontinence, and I'll see some patients that are on it for other reasons, and they have an improvement in their urinary symptoms. And then the mainstay for the treatment of stress urinary incontinence is surgery, and usually it's a sling to support the urethra. But I depict here bulking agents, which can be injected in the clinic or under anesthesia into the urethra to block the flow of urine. I like this picture that I got from Google because it looks like you're creating a prostate in a woman. And you're basically creating increased resistance to flow, the thing that men complain about, to treat stress urinary incontinence. What I like about this is it's very low risk. The surgery has almost no risk of putting a patient into urinary retention, where you can't pee. The disadvantage is it may not work and it probably won't last. But this is like my college fund for my kids. You got to redo it over and over again. It's perfect for me, right? Actually, most patients, if it doesn't work, won't do it again. And if you get a year or two, then some of my patients will buy into trying it again. So, next slide, please. Okay, so I talked about urinary retention in three contexts. One, enlarged prostate eventually may cause retention. Two, some of our medications will relax the bladder so much that you can't pee. And finally, if we do a surgery to improve stress urinary incontinence in a female, we may precipitate inability to urinate. We usually can figure it out by a history and physical exam, but sometimes a CT scan will show a big bladder. This is a bladder that's about the size of a volleyball, completely filling the pelvis. Or we have little scanners in many of our clinics that can assess non-invasively what the residual urine is in your bladder. Next slide. Most of the time, we're right when we say it's the prostate, but constipation, neurologic disorders, infection can be the cause. And in the short term, the treatment's usually catheters. You place a Foley catheter. Medications like the alpha blockers are successful about 60% of the time. We leave the catheter in for about a week to 10 days, let the bladder recover, take the catheter out, and 60% of patients will be able to urinate. But within the next year, they'll have another episode of retention about 50% of the time. In this case, we'll do a TURP usually for men. Catheters, intermittent catheterization, suprapubic tubes are alternative therapies for management of urinary retention that's not responsive to medical therapy. Next slide, please. All right, and one more, transition. So let's go over some of the impacts of Parkinson's disease on urination. So more than half of patients with Parkinson's disease have voiding symptoms. Pre-existing or coincidental urologic causes of those voiding symptoms are very common. Because Parkinson's disease, as we've heard earlier, is a disease that increases in prevalence as we age, And all these urinary conditions are diseases that increase in prevalence as we age. If a patient has the diagnosis of Parkinson's disease and has no urinary symptoms, it's estimated that almost 3/4 will eventually develop urinary symptoms. And the average time of onset is 5 years. So that's a wide range. It could be very soon after diagnosis or many years or even decades after presentation. Some of that has to do with the development of other urologic conditions as we age. And there are some very sophisticated, very limited tests that can be done to sort out, is this due to Parkinson's disease or other similar conditions that we would attribute to aging. For most of the time, it doesn't matter because we're going to try to treat them the same way. Next slide. The most common symptoms present in almost 90% of patients with Parkinson's disease is nocturia. So it's a very common symptom in men as they age and women as they age, but it's especially common in patients with Parkinson's disease. Urinary frequency is the next most common, and urinary urgency and urge incontinence is the third most common, and these affect about 2/3 to 90% of patients. The good news is Parkinson's generally is not associated with neurologic causes of inability to urinate or urinary retention. Next slide. And we think the reason is that the coordination of the sphincters is preserved, and that idea of late Parkinson's having bradykinesia, slow movements, is thought to primarily only affect a small number of patients in their external sphincter. That's the valve that you close when you don't want to urinate with voluntary signal. Maybe subconscious, but it's under voluntary control. And it doesn't squeeze quite as fast, but it does relax, and so we're able to urinate. It tends to be synergistic or coordinated function. Sometimes, though, it's not straightforward, and we'll have to do invasive testing to sort out. I do this always before doing something surgical, which I consider generally irreversible. I want to know with the best degree of confidence how to counsel a patient about what the expectations of outcomes will be. And in no patients, even those without Parkinson's, is there a 100% guarantee that you're going to have a great result from surgery. TURP is a good operation. It has a greater than 90% success rate, but it's not 100%. And the more complicated the patient, the more likely they'll not have a great result. So we have basically measure bladder pressures with catheters in the bladder and the rectum. It's a hard way, and someone watching you to watch you urinate, right? So it's not real life, but it gains a lot of information for us. Next slide. So how do we treat lower urinary tract symptoms in Parkinson's disease? Number one, we ask the neurologist to maximize your medical therapy for Parkinson's, right? So we're kicking the can back. But the research shows that the medications that manage Parkinson's disease can control all the other symptoms, and the urinary symptoms will still be present. So it's a stalling maneuver. It's a fair maneuver, because if you think about the impact of urinary urgency and frequency, sometimes it's not that you have to go to the bathroom frequently, but it's that you can't get to the bathroom. So if you can improve your motor ability with medical management of Parkinson's, then the impact of urinary urgency and frequency is mitigated. But it's also usually not going to improve the underlying urinary symptoms. So behavioral adaptation is also an important tool. So if you have urinary urgency and frequency and nocturia, and we've done everything that we can to medically manage that, maybe you need a bedside commode so you don't get up, go to the bathroom, trip on the way there, fall, and have some complication from that. We generally consider catheters and diapers a failure of the urologist to successfully manage a urinary problem. but sometimes they're the best treatment option. We're going to do medical management. So I've talked a lot about the medications that can help with urinary urgency and frequency, the antimuscarinics, the beta-3 agonists, and we're going to maximize BPH treatment. And those can provide incremental benefits in urinary symptom control. In high-quality studies of the antimuscarinics in the management of urinary frequency and urgency in patients with Parkinson's disease, they're only minor beneficial. They should be tried. They can have other benefits. They have a lot of side effects. But my experience has been they're somewhat disappointing in their effectiveness in controlling those symptoms. Next slide. So what are some of the surgical treatments? So we heard about deep brain stimulation for a select group of patients with Parkinson's. And in pretty controlled studies, this has been studied, and it can have a dramatic improvement in urinary symptoms. So I didn't appreciate that on the list of Dr. Shaw's indications. And maybe that alone is not enough, but I would be cautiously optimistic if you were otherwise a good candidate for DPS, that it would have a positive impact on urination. Botox, this is the real college fund. Botox is an amazing drug. We use it a lot beyond cosmetic reasons. In urology, we use it for idiopathic and neurogenic causes of overactive bladder. It relaxes the bladder by blocking the nerve impulses to the bladder to squeeze. It's injected into the muscle of the bladder, so it is invasive. You have to use a cystoscope. You look into the bladder. Through the cystoscope, you put a needle. Through that needle, you inject the Botox into the bladder. It works in about 80% of patients to improve bladder capacity and decrease urinary urgency and frequency. It lasts from 3 months to 12 months. You cannot inject it any more frequently than every 3 months because of the risk of developing antibodies to the Botox, which will make it less effective. And its primary risk is that of the cystoscopy, that is of infection, and of the needle injections, which is blood in the urine. But if it works too well, you won't be able to pee, so you'll develop urinary retention. The squeeze, the baffle from the beginning, doesn't push hard enough. But the good thing about Botox is it's temporary. It wears off, and the next time around, either we don't do it or we use a lower dose. And you can effectively manage the urinary urgency and frequency of Parkinson's disease-related urinary symptoms with intradetrusor Botox injection. We're nervous in men with enlarged prostate, so we got to maximally manage their BPH, but we can do it. Peripheral nerve stimulation is stimulating the tibial nerve, that's a nerve in the leg. Somehow it tricks the brain into telling the bladder not to go to the bathroom so frequently, or maybe it tricks the lower spinal cord. I've never read or heard an explanation that made sense to me and that I understood how it worked. But through many, many studies, there's strong evidence that it works. And it does work in patients with Parkinson's disease. The real challenge is that it's not universally reimbursed by Medicare. There is discrepancy among different providers about whether it's reimbursed. And also, it's not a one treatment and you're done. You got to keep doing it. But it's a reasonable thing to consider. And then I'll talk about one more time about TURP. If you have severe urinary symptoms from lower urinary tract, from the BPH, or you can't pee, accept that the urologist is reluctant to do a TURP, but don't accept that they won't do it. It should be considered, careful thought should be considered. Incontinence is a real risk, but that should not be eliminated from our treatment options. So my take-home messages are: voiding symptoms are common as we age and common with patients with Parkinson's disease. Accurate diagnosis of the cause especially before surgical intervention, might require invasive tests. But a lot of the time we're going to do trial and error with medical management to see if we can improve the urinary symptoms. And all of the treatment options that we have available for the treatment of urinary symptoms from other causes are available for patients with Parkinson's, plus one, DPS, right? We wouldn't do deep brain stimulation for someone with just an enlarged prostate, although I bet someone would. I mean, we blame it all on the mechanical aspect of the prostate blocking the urine flow, but it's much more sophisticated than that. And maybe it would work great. It'd be a hard thing to get through the IRB, I think. But we have a lot of treatment options. And their effectiveness and their risk are impacted by the presence of Parkinson's disease. Right? Doesn't mean that they shouldn't be employed, but our expectations will have to be managed to ensure that there's a congruence between what can happen and what will happen. So I think that's it. And I don't know if I have any time left or not.
I think we are right on the button.
Right on the button. So take off my mic and
give it to Dr. Siddiqui.